patient flow is a key challenge for everyone across the NHS. Nobody's cracked it. It's really tough, it's complex, and there's all sorts of challenges with it. So hence our theme for the hackathon is around patient flow. So what is today about then? Well, today is about bringing people together. We need your expertise, we need your enthusiasm, and we need your brain power.
And one of the challenges when you're thinking about complex health systems, particularly thinking about flow, is we probably all see one bit of it. Very few people, I think, see the whole. I'm not saying that people don't see the whole, but it's not in everybody's day job to actually get a chance to see the whole. So one of the things that you'll see, the exercise that we've set up, is to try and create a perspective, a shared perspective of what the whole looks like. And I think that will help to create a common understanding which will allow us to then describe the symptoms, the problems, and possibly think about some of the solutions. Patient flow is not about money. It's about safety. Okay. And the theory of, all the theory of improvement says if you do the right things, it'll cost you less. And that's a standard axiom, which is very important. Now, that's not to say that there is evidence to say that every time you improve things, we save money. I don't say that. But the principle we're batting from is doing the right thing will actually save us money. And in terms of patient flow, keeping a patient in a place where they're not appropriate to be in terms of their pathway of care is actually a patient safety issue.
We need data to be embedded in decision-making processes, and all too often it's not. And there's all sorts of behavioural, cultural, numerical reasons why that is the case. And so I'm always trying to think of new ways of trying to get over that barrier. How can we make data more accessible?
So we will create 3 project teams tomorrow. One will focus on ED, one will focus on the relationship between ED and AAU and the decision to admit, and then one will focus on the process of discharge.
And we do want you all to pitch something from up there, something that you want to be taken forward, something that you want to make a difference out of all the time that you've spent together. So is that okay? Yay! Yeah, of course it is, Kev. Yeah, we're really right up for that, definitely.
So we've split a lot of our activities into the plan, do, study and act. And we also talked a lot about whose decision is it to discharge on the wards. So that might be slightly contentious. So as a part of the plan, we felt quite confident about this, so we gave it a big smiley face, felt it was quite high. A part of our plan is making better use of systems such as CADA and Lorenzo. We've got those systems there, let's not reinvent the wheel, let's develop them to meet the needs.
Identify patients earlier in ED who are elderly and need admission, then we believe that rather than putting them through the rest of the ED process, that they can go straight up to the elderly assessment unit, so that they come in and get triaged by a nurse who then has the power to refer them straight through to the elderly assessment unit, so their time in venue is less as soon as they're on the elderly assessment unit. And at the same time, that same nurse, when triaging the patient, if she or he feels that that patient can easily be discharged, then if we can get a quick senior review of that patient, then the patient can go home.
So what do we know? Well, what we know about at the moment is that the acute medical unit introduces 1 to 2 days of non-value added time to patients who require a specialty opinion. We know that, that's evidence that we know. So how are we going to address that? Well, what we thought that we would do, we thought we'd try and keep it simple. We thought we'd start fairly small because we felt it was important to be successful before we then extended it to other specialties. So we thought that with it being winter, we would start with something like, for instance, COPD. We wish to identify the patients with help from our specialty colleagues. By discussing it with them, we could identify any learning needs that might be necessary. Although we were directed not to actually spend any money by doing this change, so we haven't introduced any additional staff. But there may be some learning needs that are necessary.
We have focused on the issue of the consultants not actioning the results. we've tried to come up with a solution in what little time that we had. Thanks Dave. Our solution is that we set up a database so that when the request comes through from the outpatient clinic, someone records it so that the secretary or management or whoever has a full understanding of how many patients are waiting for diagnostic test. And then on that same database, it'd be possible to mark when the results are back and then be able to mark when the consultant has actioned the endoscopy results. So that we have a full idea of what's happening with all patients at all times who have been sent for an endoscopy.
Our offer to you guys going forward is to support now the how to. So it feels like we've got some champions in this room that understand the challenge and have got an idea of how we can solve that.
Thank you for the ideas, thank you for the energy, thank you for the enthusiasm, it really matters to us. We will take this lot away and we will see how we can implement them. I mean, clearly, you know, there's a danger for the people who aren't in the room of us coming up with this fantastic idea and trying to drop it on them, because the human reaction will of course be to resist at all costs. So we'll have to tactfully and diplomatically drop it on them, but we will do that anyway. In 6 months' time, I very much hope that we'll be able to come back with a very positive story to tell of the outcome of your thinking and your ideas. So thank you all very much indeed.